Okay, so sorry. Okay. So as I said, I'm going to be talking about testosterone replacement therapy for whom, when, and why. Normal testosterone can be defined as a total testosterone level of 12.1 to 33 nanomoles per liter, or free testosterone of, sorry, just give us a second. Yeah. Or free testosterone.
Kerry,
Yeah?
sorry, I'm sorry to disturb you. You can just start from the beginning, please, because we're recording the presentation. There was some echo there. It could be someone who logged on, with a different device in the same room.
Sure. Okay, good morning, everyone. I'm Dr Bhana. I'll be talking about testosterone replacement therapy and answer the question for whom, when, and why. Normal testosterone can be defined as a total testosterone level of 12.1 to 33 nanomoles per liter, or free testosterone of 70 to 141 picograms per milliliter. Testosterone levels in adult men decline at an average rate of 1 to 2% per year. This change can be caused by the normal physiological changes of aging, testicular dysfunction, or hypothalamic pituitary dysfunction. Hypergonadism is defined as a low serum testosterone level coupled with certain signs and symptoms. In men aged 40 to 79 years, the incidence of symptomatic hypergonadism varies between 2.1 and 5.7%. Adult onset hypergonadism, specifically associated with aging, usually occurring but not exclusively in men aged older than 40 years, is called late onset hypergonadism. Depending on the causes, late onset hypergonadism can be persistent or potentially reversible. There's a high prevalence of hypergonadism within specific populations, including patients with type 2 diabetes, metabolic syndrome, obesity, cardiovascular disease, chronic obstructive pulmonary disease, renal disease, and cancer. Quick overview of the testosterone physiology. The hypothalamus releases gonadotropin-releasing hormone, which travels via the portal vascular system to stimulate the release of luteinizing hormone and follicular-stimulating hormone from the anterior pituitary. FSH and LH then act on the gonads. LH acts on Leydig cells in the testes, stimulating steroidogenesis by inducing the mitochondrial conversion of cholesterol to testosterone. FSH acts on Sertoli cells to stimulate spermatogenesis. Testosterone and inhibin B have a negative feedback mechanism which inhibits gonadotropin release. Normal testosterone production in men is approximately 5 grams per day. Secretion occurs in a pulsatile manner and is usually the highest in the morning. Circulating testosterone are bound either to low affinity, high availability proteins, primarily albumin, or to the high affinity glycoprotein, 6-hormone binding globulin. These binding proteins play an important part in regulating the transport, distribution, metabolism, and biological activity of the sex hormone. Testosterone is metabolized into 2 major active metabolites in target tissues: dihydroxytestosterone from the action of 5-alpha reductase and estradiol through the action of aromatase. So testosterone is responsible for primary sexual development, which includes testicular descent, spermatogenesis, enlargement of the penis and testes, and increasing libido. Testosterone is also involved in regulating secondary male characteristics. These secondary sex characteristics include male hair patterns, vocal changes, and voice deepening. Anabolic effects include growth spurts in puberty as testosterone increases tissue growth at the epiphyseal plate early on and eventual closure of the plate later on in puberty, as well as skeletal muscle growth as testosterone stimulates protein synthesis. Testosterone also stimulates erythropoiesis, which results in a higher hematocrit in males versus females. So signs of symptoms of late onset hypogonadism are usually chronic in duration and may encompass a wide range of clinical presentations. Physically, the patient might complain about muscle loss or weakness, hot flushes, weight gain, hair loss, and lower urinary tract symptoms. Common sexual complaints are decreased libido, erectile dysfunction, and loss of spontaneous morning erections. Mentally, the patient might report fatigue, memory loss, irritability, decreased concentration, and lack of sleep. So why should we give patients testosterone? While the benefits of testosterone replacement treatment are thought to be improved sexual desire and function, increased bone mineral density, therefore decreasing the risk of osteoporosis, improved mood and energy and quality of life, change body composition and improve muscle mass and strength, improve cognitive function, improvement in lipid and glycemic control, thereby decreasing the risk of diabetes and metabolic syndrome. In 2018, Snyder et al. Published the testosterone trials, which were a set of 7 placebo-controlled double-blind trials in 788 men with a mean age of 72 years, to determine the efficacy of increasing testosterone levels of older men with low testosterone. Testosterone treatment increased the median testosterone level from low at baseline to mid-normal for young men after 3 months and maintained that level until month 12. There were 3 main trials assessing sexual function, physical function, and vitality, and 4 sub-trials assessing cognition, bone, anemia, and cardiovascular risks. The studies demonstrated benefits in 4 trials, namely sexual function, vitality, bone, and anemia. Partial benefit in the physical function trial, no effect in the cognition trial, and a negative effect in the cardiovascular trial, but that trial was criticized as being underpowered. This trial, along with other studies, have confirmed the many benefits of testosterone replacement therapy. So metabolic syndrome. So metabolic syndrome is characterized by an increased waist circumference, dyslipidemia, hypertension, and impaired glucose tolerance. Hypogonadism is associated with central obesity, hyperglycemia, insulin resistance, and dyslipidemia. Hypertension and a predisposition for type 2 diabetes, which are all components of metabolic syndrome. Multiple studies in obese hypogonadal men with type 2 diabetes found that testosterone replacement therapy significantly reduced fasting blood glucose, HbA1c levels, reduced total cholesterol, low density lipoproteins, triglyceride, inflammatory marker levels, and increased HDL, as well as improved systolic and diastolic pressure. The contraindication for testosterone replacement therapy can be divided into absolute or relative. Absolute contraindications are locally advanced or metastatic prostate cancer, breast cancer, but with breast cancer, there's no known physiological link of testosterone directly to the development of breast cancer. It has been suggested that the physiological link is that the development of breast cancer is due to the high levels of testosterone, which may lead to increased aromatization to an active derivative of estrogen, which ultimately may stimulate breast tissue receptors and increase the risk of male breast cancer. In men with an active desire to have children, testosterone therapy is contraindicated, as it suppresses gonadotropin and endogenous testosterone secretion, as well as spermatogenesis. Hematocrit of greater than 54% can result in potential cardiovascular complications. And lastly, uncontrolled or poorly controlled congestive cardiac failure. Relative contraindications are a familial history of venous thromboembolism, a baseline hematocrit of 48 to 50%, and patients with severe lower urinary tract symptoms, usually with the IPSS score greater than 19. So going into more details about the contraindications and side effects, an elevated hematocrit is the most commonly adverse side effect of testosterone therapy. Stimulation of erythropoiesis is a normal biological action that enhances delivery of oxygen to testosterone-sensitive tissues. Any elevation above the normal range for hematocrit usually becomes evident between 3 and 12 months after testosterone initiation. However, polycythemia can also occur after any subsequent increase in testosterone dose, switching from topical to parenteral administration, or development of comorbidities, which can be linked to an increase in hematocrit, such as respiratory or hematological diseases. If the hematocrit exceeds 54%, there's a testosterone-independent but weak associated rise in cardiovascular events and mortality. With testosterone therapy, an elevated hematocrit is more likely to occur if the baseline level is towards the upper limit of normal prior to initiation. Added risk for raised hematocrit on testosterone therapy includes smoking, respiratory conditions, and parenteral rather than topical formulations. Elevated hematocrit in the absence of comorbidities or venous thromboembolisms can be managed by a reduction in testosterone dose, change in formulation, or if the elevated hematocrit is very high, by venesection. Testosterone replacement therapy in prostate cancer. For a long time, it was believed that higher testosterone concentrations increased the risk of prostate cancer or caused rapid cancer growth, while low testosterone concentrations would have a protective outcome. This paradigm has shifted with the prostate saturation hypothesis by Morgan Taylor, that when androgen receptors on the prostate become saturated, the prostate becomes insensitive to further serum testosterone increases, such as with testosterone replacement therapy. The saturation model impels a change in the traditional teaching that testosterone is like food for a hungry tumor. Rather, it suggests that testosterone is like water for a thirsty tumor. The critical distinction is that once thirst is quenched, additional water serves only as excess. There are several important implications and predictions of the saturation model. Reducing serum testosterone concentrations below the saturation point will reduce serum PSA and cause reduction in prostate volume for men with benign or malignant prostate tissue. Raising the serum testosterone in men with levels anywhere below the saturation point will result in a rise in PSA and tissue growth. Androgen-driven growth is maximal at the saturation point. Increases in serum testosterone level above this level resulted in limited or no additional growth. And lastly, men with serum testosterone far below the saturation point will demonstrate greater increases in PSA with testosterone therapy than men with serum concentrations slightly below the saturation point. So testosterone therapy and the risk of developing prostate cancer. Multiple studies have not demonstrated testosterone concentrations to be higher in men with prostate cancer compared to those without cancer. Reports have shown that hypogonadal men with normal PSA levels do not have lower cancer rates than the general healthy population. A UK-based retrospective database review published in 2019 by Santinella et al. Identified 12,779 patients with late onset hypogonadism. The mean follow-up period was 4.6 years, though 37.3% and 9.2% of patients received a follow-up for 5 and 10 years respectively. The use of testosterone therapy in this population did not result in any increase of prostate cancer in the overall analysis. In 2015, Hayder et al. Reported the observation of 3 registries on the incidence of prostate cancer in 1,023 hypogonadal men receiving testosterone replacement therapy, followed up for 5 years. The authors also found that testosterone replacement therapy does not increase the risk of prostate cancer. Testosterone replacement therapy and active surveillance. The most risky population for testosterone therapy with regards to non-metastatic prostate cancer are men on active surveillance. In 2011, Morgan Taylor et al. Reported the results of prostate biopsy, serum PSA, and prostate volume in 13 hypogonadal men on active surveillance who received testosterone replacement therapy for untreated prostate cancer for 2.5 years. Although the men experienced a 2.8-fold increase in serum testosterone levels, there was no significant change in the mean PSA. These researchers noted that all men receiving testosterone replacement therapy also experienced symptomatic improvement in libido, sexual performance, mood, and energy. In 2014, an analysis of the SEER Medicare data, Kaplan et al. Estimated that between 1991 and 2007, 0.79% of men received exogenous testosterone after prostate cancer diagnosis. Men on active surveillance were noted to be less likely to receive testosterone replacement therapy overall, and cancer-related mortality was higher in the non-testosterone replacement therapy groups when compared with the testosterone replacement group. Limitations on this study included only evaluating a 5-year follow-up period and potentially unreliable clinical information. Published reports indicate that approximately 25 to 30% of men on active surveillance protocols will demonstrate disease progression over 3 to 5 years, even without testosterone therapy. So it still remains controversial to administer testosterone therapy in this population. In testosterone therapy and localized prostate cancer. In 2020, a large cohort analysis by Sakar et al. Identified 69,984 men with localized prostate cancer, of whom 28,651 underwent radical prostatectomy and 41,333 received radiation. Of this total number, 1.64% of radical prostatectomy patients and 1.31% of radiation patients received testosterone replacement therapy with a mean follow-up of almost 7 years. The investigators found that comparing those men who received testosterone replacement therapy with those who did not, there was no between-group differences in biochemical reoccurrence, prostate cancer-specific mortality, or overall mortality after surgery or radiation. One strength of the study was that it pooled a large multi-ethnic nationwide cohort with a high prevalence of African American men. In 2020, Allering et al. Examined the rates of biochemical recurrence in 850 patients who underwent radical prostatectomy for localized prostate cancer, of whom 18% were started on testosterone replacement therapy. After a median follow-up of 3.5 years, biochemical reoccurrence occurred in 7.2% and 12.6% of patients in the testosterone replacement therapy and control groups, respectively. Testosterone replacement therapy was an independent predictor of recurrence-free survival. After accounting for Gleason grade, pathological stage, preoperative PSA, and calculating free testosterone, the authors determined that patients prescribed testosterone replacement therapy were about 54% less likely to reoccur. Among those men who would eventually reoccur, testosterone replacement therapy appeared to delay time reoccurrence by an average of 1.5 years. Importantly, the study reported that by 2 years post-radical prostatectomy, 96% of patients had regained erectile function. So testosterone replacement therapy in patients with advanced prostate cancer. This is the most risky group in men with advanced recurrent or metastatic disease. It is to be expected that PSA will rise in these patients over time, regardless of whether they receive testosterone therapy. Many will eventually die from prostate cancer. Any evidence for disease progression in the setting of testosterone therapy will be attributed to a high testosterone. It is mandatory to avoid testosterone administration in men with advanced prostate cancer. Extreme caution in men currently on ADT, particularly if ADT has been instituted to treat metastatic disease. The likelihood is that whatever initial clinical benefit that accrued from ADT will be reversed with testosterone therapy, with the possibility of even greater disease progression. Testosterone replacement therapy may have an important therapeutic role in the treatment of hypogonadism in those men with either low risk, active, or previously treated prostate cancer. It is not uncommon for prostate cancer patients to also be diagnosed with testosterone deficiency at any stage in their disease, whether it's before treatment, after cure, from those with biochemical reoccurrence or inactive surveillance. So when it comes to BPH and LUTs, based on the assumption that prostate growth is dependent on the presence of androgens, historically, testosterone therapy has raised concerns regarding the possibility of aggravating LUTs in patients affected by benign prostate hyperplasia. However, preclinical, clinical data have indicated that low rather than high testosterone, high androgen levels may decrease bladder capacity, alter tissue histology, and decrease the ratio of smooth muscle to connective tissue, thus impairing urinary dynamics. According to recent literature, there's no reason not to treat men with hypogonadism and LUTs or BPH, unless they have severe LUTs or an IPSS of greater than 19, as these patients were generally excluded from random controlled trials, therefore limiting the long-term safety data. So late onset hypogonadism is associated with cardiovascular risk factors, including central obesity, insulin resistance, and hyperglycemia, dyslipidemia, prothrombic tendencies, and chronic inflammatory states. Evidence from random controlled trials of testosterone therapy in men with metabolic syndrome and or type 2 diabetes demonstrates some benefit in cardiovascular risks, including reduced central adiposity, insulin resistance, total cholesterol and LDL cholesterol, and suppression of circulating cytokines. No random control trials have provided a clear answer on whether testosterone therapy affects cardiovascular outcomes. Testosterone therapy is also contraindicated in men with severe chronic cardiac failure because fluid retention may lead to exacerbation of the condition. If a decision is made to treat hypogonadism in men with chronic cardiac failure, it is essential that the patient is followed up carefully with clinical assessment and both testosterone and hematocrit measurements on a regular basis. So the treatment options. Lifestyle modification. As mentioned earlier, hypogonadism is related to metabolic disturbances such as type 2 diabetes, metabolic syndrome, or obesity. Therefore, treating the underlying metabolic condition may be the most rational approach. In obese men, physical activity, in particular moderate to intense aerobic exercise, induces an increase in total testosterone and free testosterone levels. The effect of physical activity on testosterone seems to be greater than a low-calorie diet. Severe and moderate deficiency of zinc is associated with hypogonadism in men. Zinc and vitamin D supplementation may increase total testosterone and improve sperm count, but this recommendation is not part of any guidelines. The use of oral testosterone was limited due to the associated liver toxicity of testosterone, which are related to the large doses required to achieve a normal serum level, as testosterone is rendered metabolically inactive during the first pass circulation through the liver. The esterification of testosterone with long-chain fatty acid called testosterone undecanate enables testosterone to be absorbed by the intestine through the lymphatic system, bypassing liver metabolism. It has been available since the 70s in oleic acid, and more recently in castor oil and propylene glycol laurate mixture, allowing it to be kept at room temperature without degradation. The dosage is usually 120 to 240 milligrams, 2 to 3 times a day. Its limiting factor is it has shown a large individual bioavailability, as absorption is reliant on the patient's dietary fat intake, as well as variability for the time for maximal responses, as well as when the maximal serum testosterone is attained. Injectable testosterone preparations can be classified according to their half-lives. Testosterone propionate is delivered intramuscularly at a dosage of 50 milligrams every 2 to 3 days because of its short half-life of 20 hours. It also displays serum testosterone fluctuations. Testosterone enanthate has a half-life of 4 to 5 days and cypionate of 8 days. Both are injectable depot preparations of testosterone delivered by deep intramuscular injection every 2 to 3 weeks. This results in supraphysiologic levels of testosterone for 72 hours, with a steady exponential decline to subphysiologic levels by 10 to 12 days. These fluctuations in testosterone levels may yield variations in libido, sexual function, energy, and mood. Testosterone undecanate has a half-life of 34 days and is a depot formulation consisting of 750 to 1,000 milligrams administered at 10-week dosing intervals. The benefit of using testosterone with short half-lives versus long-acting depot is it allows for the drug withdrawal if adverse effects are experienced. Intramuscular injections can cause local pain, soreness, bruising, erythema, swelling, nodules, or furuncles. Subdermal, and the pellets made of pure crystals of testosterone are compressed into short rods, are implanted under local anesthesia into subdermal fat through an incision in the lower abdominal or upper buttock skin. Dosaging is usually 2 to 6 pellets or 150 to 450 milligrams of testosterone implanted subcutaneously every 3 to 6 months. Complications of the pellets are implant site infections and pellet extrusion, which is quite frequent at 5 to 10%. Transdermal testosterone. Testosterone gels represent the most frequent used preparations. The gel is quickly absorbed by the stratum corneum, creating a reservoir within the subcutaneous tissues, from where testosterone is continuously delivered for 24 hours after a single daily application. These formulations have been shown to normalize serum testosterone levels with an excellent safety profile. The testosterone 1% gel is topically applied once daily in the morning to clean dry skin on the shoulders, upper arms, or abdomen, and is allowed to dry before dressing. Transdermal testosterone formulations include a topical alcohol-based testosterone of 2% solution, which must be applied to the underarms once daily using a special metered dose applicator. Special considerations for axillary administration include the concealable location and high permeability of the axilla. Initially, testosterone patches were administered daily to the scrotum, but its use faltered because of difficulties with application requiring scrotal shaving. An alternative formulation avoiding the inconvenience of the scrotal application was developed, where the patch was applied to the arm, back, or buttock as a 5 milligram patch. Both patches have been associated with itching, chronic skin irritation, and allergic dermatitis. Transmucosal delivery systems have been developed for improving testosterone absorption because mucous membranes are more permeable than skin. Transnasal requires administration 2 to 3 times daily using a specific meter dose pump. The application is rapid, non-invasive, convenient, and avoids secondary transference observed with other topical products. Some of the disadvantages are the possible irritating nasal route of an administration and necessity of an administration up to 3 times a day. The transbuccally, it consists of a sustained release mucoadhesive buccal testosterone tablet requiring twice daily application to the upper gums. The tablet does not dissolve completely in the mouth and must be removed after 12 hours. This formulation has been proven to restore testosterone levels within the physiological range with minimal or transient local problems such as gum edema, blistering, and gingivitis. The follow-up for patients varies for different parameters. Clinically, the patient's symptoms, waist circumference, blood pressure, and a DRE should be done before starting treatment and repeated at 3, 6, and 12 months. Biochemically, a PSA, hematocrit, testosterone level, lipid, and glycemic profiles must be done as a baseline and then monitored at 3 and 6 and 12 months, except for the lipid and glycemic profile, which can be monitored at 6 and 12 months. If there are no concerns at 12 months, then all these parameters can be monitored annually. So in conclusion, to answer the question for whom, when, or why, testosterone therapy should be administered to appropriately selected patients who have symptomatic hypogonadism, taking into careful consideration the relevant contraindications mentioned, preferably using transdermal gel delivery or long-acting injectable testosterone undeconate, as these provide pharmacokinetic behavior that gives a steady state level within a physiological range. Testosterone levels within the physiological range have shown to provide a wide range of benefits, which would improve a patient's quality of life. Further studies also need to be done to assess the role of testosterone in prostate cancer. Thank you.